question, and also the multiple small causes which come as a part of hemolytic anemia can also be asked individually in your long questions. So first of all, these are the major objectives that we'll go through in our class. Okay, and first of all, important thing, definition. So we all know anemia. Anemia is a fall in hemoglobin. What does hemolysis means? Hemolysis means there is RBC destruction along with increased erythropoiesis. So because of the excessive breakdown of the RBCs, there is anemia. And how can it be possible? It is possible if there is reduced lifespan, if there is, premature destruction because of the autoantibodies infections, which will lead to premature destruction of RBCs. So, in response to the RBC destruction, the bone marrow releases more of erythropoietin, which causes increased erythropoiesis. So, and the major thing about hemolytic anemia is the retic count. Retic count is usually more than 2%, and if we go about absolute retic count, it is more than 1 lakh per microliter. So, hemolytic anemia either can be because of hereditary causes or it can be acquired causes. Then, it can be intracorpuscular causes or extracorpuscular defects. So, then intracorpuscular means the defects which lie within the RBCs, which make it more prone to premature destruction. Or it can be extracorpuscular defects which make it prone to destruction, like antibodies are being formed, some increased antigen presentation, but that is mainly extracorpuscular defects. While intracorpuscular means the defects in the membrane, deficiency of the enzymes. So that is intracorpuscular defect. Then it can be intravascular hemolytic anemia or extravascular hemolysis, depending upon the site of hemolysis. So extravascular hemolysis can occur in liver or spleen, while intravascular is very clear that it occurs within the blood vessels. So generally what is said is the intracorpuscular defects are mostly hereditary defects, while extracorpuscular defects are mostly acquired defects, though we have exceptions and we'll be dealing with these defects, individually in detail. So intracorpuscular defects, which are mainly hereditary, are mostly hemoglobinopathies, your enzyme deficiencies, your membranous defects, while acquired causes paroxysmal nocturnal hemoglobinuria. While extracorpuscular defects are mostly like acquired causes, that is autoimmune, fragmentation hemolysis because of the drugs, toxins, infections. While hereditary causes can be familial HUS, that is hemolytic uremic syndrome, or it can be A beta lipoproteinemia. So coming to the hemoglobinopathies. Hemoglobinopathies, we all know it is thalassemia, sickle cell anemia, methemoglobinemia, or hemoglobin like CED, because there is a problem with the hemoglobin itself. The hemoglobin chains are not properly formed, making them more prone to destruction. Then there can be enzyme deficiency, that is pyruvate kinase and G6PD deficiency. G6PD deficiency is mostly seen in males and it is more common as compared to pyruvate kinase deficiency. Then there are membrane defects, that is hereditary spherocytosis, elliptocytosis, that is just the defect in the membrane shape because of the deficiency of the cytoskeletal proteins. So they become more prone to hemolysis. What is fragmentation hemolysis? Fragmentation hemolysis is like any process which is going on in the body, like DIC, HUS, TTP, or burns, any thermal injury, any prosthetic heart valve, through which when the RBCs run through them, they become more prone to destruction. So this is just the extra in the extravascular, that is the liver and the spleen. The RBCs get break down into globins, iron, and protoporphyrin chains. So what happens is there is increase in the bilirubin. So there is increase in the urobilinogen in the urine and stercobilinogen in the feces. While in intravascular hemolysis, this breakdown usually does not occur. And what happens during the breakdown of RBCs, there is free hemoglobin. So this free hemoglobin, some amount of it gets converted into methemoglobin, while this hemoglobin is excreted to the kidney as hemoglobinuria or hemosideриnuria. Okay, so this is the main differentiating factor how we reach whether it is the extravascular hemolysis which is going on in the body or the intravascular hemolysis. That is just a repetition of words. So one important thing is how do we diagnose that yes, this is a hemolytic anemia which is going on. The important thing is the hemolytic anemia, the, we know there is anemia, but we have to confirm that there is a hemolysis process which is going on. And then we have to determine the etiology of hemolysis that I have just shown you. There can be multiple causes of hemolysis in any child. Okay. So, how do we suspect a hemolysis? Hemolysis is suspected when there is a new onset or sudden onset of pallor or anemia, along with jaundice, splenomegaly, and if you know there is bilirubin, excessive bilirubin production, it can lead to gallstones, dark-colored urine, and as well as leg ulcers. So these are the main things which gives us a clue of an underlying hemolysis. What happens is you, even if the child is coming with anemia, you transfuse them with a PRBCs, but again, the fall of hemoglobin is too fast. That means even the RBCs that you are transfusing, it gets break down very easily. So that is one feature which gives you that even with the transfusions, your hemoglobin is not getting built up. Okay. So how do we diagnose this? We diagnose this through the evidence that there is RBCs breakdown, destruction, hemoglobin destruction. So there is increase in the unconjugated bilirubin, urinary urobilinogen, stool stercobilinogen, LDH is also increased in that, and also there are various hemoglobin binding proteins in the serum, in the blood. So whenever there is excessive free hemoglobin is there, so those proteins concentration become less because they all get occupied while being bind to hemoglobin. Free proteins are less, that is heptoglobin, hemopexins. So these tests are also available in the private labs nowadays, which give us a clue. Then evidence of RBC damage because of the defects in the membranes that occur, which we get through the peripheral smear in the form of spherocytes, cystocytes, target cells, and we can do RBC survival studies also. The RBC survival studies which help us to tell the duration of this of RBC survival. That is, at what time are they getting destroyed in the body. Then increased RBC production is mainly done through reticulocytosis, that is erythroid hyperplasia is there, and through the if we go through the some special X-rays, we'll see that there is bone marrow hyperplasia, there is excessive erythropoiesis, which leads to bone cortex thinning and widening of the intratrabecular spaces. Okay, and if there is intravascular hemolysis, as we have discussed before, there is hemoglobinemia, there is hemoglobinuria, and hemosideronuria if this persists for too long. This is just a tablet picturization of what we have already told you. So, what is main feature is in intravascular hemolysis, there is hemoglobin and hemosiderin concentration is high in the urine, while the bilirubin is more high in extravascular hemolysis. Then the heptoglobin levels are decreased in extravascular while they are almost absent in intravascular. So these are the small clues which will help you to identify the main cause of the hemolysis. So coming to the individual causes which are important. So hereditary spherocytosis, as you all know, the RBCs which are mainly biconcave in shape, they become more spherical. So they lose their biconcave. You can see this is a normal RBCs with their biconcave shape, but they become more spherical. So what happens is they are not able to pass the blood vessels so easily, and they get breakdown. So why it is mostly an autosomal dominant disorder, but yes, there can be spontaneous mutations also. Okay, so there is deficiency of beta spectrin or ankyrin protein, which makes the surface change. Clinical features is that in these children can present with a prolonged jaundice during the first month of life, and which might require phototherapy or exchange transfusions. And as later on in the age, they can present with anemia, pallor, jaundice, splenomegaly, gallstones. So this is the normal biconcave shape which you can see, and these are the spherical RBCs which you can see. So how do we diagnose? The main diagnostic test that we do is some are common tests for hemolysis, that is reticulocytosis, anemia, indirect hemoglobin hyperbilirubinemia, and important thing is the MCHC is increased in these cases because the RBCs become more severe. The concentration of of hemoglobin increases in them. Okay, and the best test that we have is a flow cytometric eosin 5 meldamide test. Okay, initially what we used to do earlier was a osmotic fragility test. This is mostly a screening test. This is not a specific test or which is a diagnostic test. No, you can do a first screening test, but later on you have to do these tests like cryohemolysis test or EMA binding test. And what is the treatment? The treatment for hemolytic anemias is usually, more or less same only. You need proper visits to hematologist, you need a growth monitoring, you need to document the spleen size because when the spleen size is excessively large, we might need to do a splenectomy because to avoid the complications. Okay, so folic acid supplementation is also given and counseling of the parents because if one is the genetic counseling for the future siblings, then also there can be aplastic crisis secondary to various viral infections, mostly parvovirus, which what happens is when there is the parvovirus infections or other virus infections, the bone marrow has a complete shutdown. There is not only anemia which is there, there is leukopenia, there is thrombocytopenia, there is an increased risk of infections, increased risk of bleeding episodes, and which can even lead to a catastrophic event in the end. Okay, so these are all the complications which might arise, and we need to counsel the parents beforehand. Then splenectomy is done in cases with moderate hereditary spherocytosis, which might have a aplastic crisis, poor growth, but it is usually done after the age of 6 years only. Before that, and before doing a splenectomy, we need proper vaccination against pneumococcus, meningococcus, and H influenza B at least 2 weeks before. And after the splenectomy, we have to put them on prophylaxis with penicillin. Okay, so this is very important and it's true for everyone. Now coming to the next one, that is the hemoglobinopathies. We all know thalassemia is the most common hemoglobinopathy. But the what is this is the normal hemoglobin distribution that we have on electrophoresis. That is hemoglobin A is more than 95%, A2 is less than 3.5%, and F is less than 2.5%. Okay. So coming to the sickle cell disease first, we all know that it is an autosomal recessive disease. What happens is a single glutamic acid gets changed to valine at position 6 of beta chain, and which leads to sickle cell disease. So a sickle cell disease means it is a homozygous state, while a sickle cell trait that is a heterozygous. So mostly these children, heterozygous children, don't have any problem. They have adequate concentration of hemoglobin A, and they don't have mainly crisis. But a homozygous state is they have more of hemoglobin S, more complications, and a reduced lifespan. So what happens in this? This is just I'm just telling you. Glutamic acid is replaced by valine. This is the hemoglobin S, which is formed. So what happens during oxygenation? There is not much of a problem. The hemoglobin gets oxygenated. But when at the tissue level there is deoxygenated, or if in case of any stress or sepsis, any exercise, anything is there, then there is more oxygen demand, there is more deoxygenation, and there is polymerization of the hemoglobin S. This polymerization leads to the shape of the cell RBCs being changed to the sickle cells. And these sickle cells are not able to transverse our blood vessels so easily, which leads to vasoocclusion. They can lead to organ ischemia and also the end organ damage and lead to crisis. And how does this sickling is precipitated? By hypoxia, acidosis, dehydration, infection, and they have, the sickle cells which they have very short lifespan, and they plug in the microcirculation, and it can lead to various crises, that is vaso-occlusive crisis, acute chest syndrome, sequestration crisis, and aplastic crisis. What do they have is an anemia. They have sickle cells on the blood films. Okay, and an electrophoresis diagnostic feature of thalassemia or even your sickle cell anemia is hemoglobin electrophoresis when the concentration of normal hemoglobin A is much less than the other hemoglobin. So this is a 3D picture of showing you the sickle cells, and this is the normal biconcave shape of the RBC. Now, complications. These are the manifestations as well as the complications which arise in the children with the sickle cell anemia, fever, and bacteremia. That is means sepsis. So, any fever in a child with sickle cell anemia is an emergency. Okay, what happens is by 5 years of age, these children they have splenomegaly, but functionally the spleen is not functional because they all has been destroyed. So they are at increased risk of infections and death by the same organisms, but also with salmonella and staphylococcus. So whenever there is a fever, it is, becomes an emergency and need to be treated properly with the antibiotics. Then there is splenic sequestration crisis. It is also a life-threatening complication which occurs with rapid spleen enlargement, causing a left-sided abdominal pain and also fall of hemoglobin, which is around at least 2 grams per deciliter. There's fever, viral infections, bacteremia, and this can cause. What happens in those cases? We have to give them fluids, okay, and we also need to give them blood transfusions. But it has to be very careful. Why? Because uh, it is we what we're giving a blood transfusion during a sequestration. It is used also to treat the sequestration and also treat the anemia as well. So it has to be given, but it's not given in large volumes. It is given at the rate of 5 ml per kg. And of course, prophylactic splenectomy is done after the acute episode is over. Now, vaso-occlusive crisis occurs, in small blood vessels. Small blood vessels to our digits, to our fingers, toes. So there is occlusion of those blood vessels by the sickle cells, reducing the blood flow, causing ischemia, and there is a severe pain. Okay, so we all know the precipitating factors as we have already done: stress, infection, hypoxia, acidosis, exposure to cold. So there is extreme skeletal pain which is there, and we have to differentiate it from osteomyelitis. These children are to be given NSAIDs, strong NSAIDs are given so as to decrease the pain as far as possible. Then is acute chest syndrome is also a life-threatening pulmonary complication. It is defined when there is a new radio density on the X-ray along with any two of the following, that is fever, distress, hypoxia, cough, or chest pain. We need a blood transfusion, which can be a normal blood transfusion, and in extreme cases, we might need a exchange blood transfusion. Then we have to give oxygen, antibiotics, bronchodilators, and pain control, as well as the fluid management. Aplastic crisis in sickle cell is same as any hemolytic anemia because, as we have discussed in hereditary spherocytosis, that is the same in this is a picture explaining the various manifestations of the sickle cell disease and various complications that it can arise. It can lead to stroke, paralysis, retinopathy, avascular necrosis of shoulder, hip, hematuria, okay, autosplenectomy, abdominal pain, dactylis, osteomyelitis, chronic ulcers. So these all are the complications as well as the manifestations of sickle cell. So, which drug is really helpful? The only drug which has been proven to be effective in reducing the painful episodes is hydroxyurea, and along with that, we give folic acid. Immunizations need to be done to the children around 6 years of age, and the only cure that is available is a HLA matched hematopoietic stem cell transplantation. Okay. Now, next group of hemoglobinopathies is the thalassemia syndrome. Thalassemia is, as you all know, because what happens in thalassemia, there is problem with the globin chains. Either it can be alpha globin chain problem or beta globin chain problem. So we call them as same as alpha thalassemia or beta thalassemia. Okay, there are multiple mutations that are available, thousands of mutations which is possible. So what we commonly present in North India is a beta thalassemia. Alpha thalassemia is not that common. And we have divided them into major, intermediate, minor, depending upon the, how many genes are presented, what is the status of the mutation. If it is a homozygous mutations, it has a more severe presentation. If it has just one thalassemia, gene, which is the chain is absent while the rest are present. So and depending upon the severity of the mutations and the normal thalassemia, beta thalassemia chain present, it is divided into major, intermediate, or minor. So the same thing happens in that in major there is severe anemia, hepatosplenomegaly, multiple blood transfusions leading to complications of iron overload. Okay, while in minor it is just like a mild anemia of 10, 10.5, and important thing is they become a carrier for your future generation, and they can lead to thalassemia. Okay, so mostly the children are asymptomatic till 3 to 6 months of age, and why is that? It is because hemoglobin F persists till 6 months of age and it doesn't lead to much of the problems then. While when the concentration of hemoglobin F starts decreasing, the concentration of hemoglobin A too increases and lead to complications. There is pallor, hepatosplenomegaly, failure to thrive, and thalassemic facies. Thalassemic facies have flat nasal bridge. They have maxillary hyperplasia and frontal bossing. So this is a typical thalassemic facies. There is maxillary hyperplasia, frontal bossing, flat nasal bridge. And the X-rays, you have a hair on end appearance. Okay, due to the various radiations, which is our new bone formation on the outer table. So these are the very typical features. These are the mainly features because of the increased erythropoiesis that is happening in the body and the bone marrow. Diagnosis is through peripheral smear, hemoglobin electrophoresis, and also the mutation analysis that is being done nowadays. So what happens in this? There we have nucleated RBCs. We might have target cells or hypochromic cells that are available. Along in thalassemia, even thalassemia or any other hemolytic anemia in which you need repetitive blood transfusions, regular blood transfusion, it can lead to excessive iron overload in the body. This iron can get deposited in the liver, your heart, all the major organs and decrease their functioning over time. So what we need is a chelation therapy along with that in the form of oral chelation therapy or subcutaneous one. So oral is, if I say you, it's defipiron, defacirox, while subcutaneous ones is deferoxamine. So these are different doses which are given. They are effective. They have to be given regularly. These children have to be kept under continuous monitoring. They need to be evaluated for the viral markers because any child who's repeating repeated blood transfusion at high risk of acquiring infections due to blood transfusions. That is HS, hepatitis B, hepatitis C, and as well as HIV also. So they need to be there. And the only best cure that is available is the hematopoietic stem cell transplantation. Now, complications. Complications is same as I told you. There is liver hemosiderosis. There can be hypothyroidism. If that iron get deposits in the pituitary, it can lead to hypogonadotrophic hypogonadism, growth hormone deficiency, diabetes, hypoparathyroidism. So these are the various complications. So these children have to be under continuous monitoring. They have to have a regular visits with the thalassemia center. We have daycare centers in various hospitals. So they don't only give the blood transfusions, stimulation therapy, but they also regularly monitor the child in form of their height, weight, hemosiderosis if there is developing, then chelation therapy. But there are multiple aspects to it. They need to do their growth whenever there is a puberty time. They do their growth hormone evaluation, thyroidism, hypothyroidism, liver, LFTs, risk of viral infection. So that has to be continuously monitored in those children. Okay, so simple method to monitor the iron status is the serum ferritin. And in cases when where we suspect complications or there has been multiple transfusions, we do liver MRI or echocardiography. Okay, so non-invasive tool mainly to assess the cardiac status is the MRI that we do. Now coming to the G6PD deficiency, it is X-linked disorder because of the deficiency of the enzymes glucose 6-phosphate dehydrogenase deficiency. What happens is whenever there is an exposure to any oxidative agent, which can be mostly drugs, infections, there are acute hemolysis episodes because of the deficiency of NADPH. So whenever there is G6PD deficiency is there, so it leads to inadequate supply of NADPH, reduced levels of glutathione, because glutathione is in our body prevents oxidation. So when it is not there, the oxidation is not prevented and it leads to oxidative damage. It is of two types, A minus, B minus, and cannon type depending upon the percentage of the enzyme activity that is present in the body and the severity. Okay, so if the canton is markedly reduced activity, so it's severely deficient, while A minus has an enzyme activity of around 5 to 15%, while B minus has less than 5%. So if the deficiency is more, the manifestations are more. So what happens is in those G6PD deficiency patients, we need to give the parents an extensive list of drugs that they need to avoid, and they need to be telling their doctors, so that otherwise any drug when given can lead to acute crisis hemolysis and can be detrimental to the life of the child. There is sudden pallor, jaundice, same things that have happened. And the diagnosis thing is in the peripheral smear, we see the hinge bodies. Hinge bodies is when there is destruction of the RBCs, the hemoglobin gets destroyed and get collected in the cytoplasm, which leads to the hinge bodies. Okay, and the definitive test is mainly through the enzyme assays that we do. And of course, if you want nowadays, for every disease, there is a gene analysis thing that is available, and you can do that. So this is the hinge bodies that is available in the cytoplasm collected on one side. Management is mainly prevention. So if these children avoid those drugs, then they really don't need anything. They can have a normal lifespan, normal life. But if a hemolysis occurs, then a supportive therapy with blood transfusion is given. Another enzyme deficiency is pyruvate kinase deficiency, in which what happens is marked reduction in the pyruvate kinase lead to, or abnormal enzyme is there. So what happens is sodium potassium pump does not function properly. They don't get a good amount of ATP. So because of this, they are not able to maintain the biconcave shape of the RBCs, and it becomes speculated RBCs. Okay. So what happens is there is polychromatophilia, there is increased retic count, there are speculated RBCs if you can make out in this figure, and reduction of the pyruvate kinase activity. Another important feature of pyruvate kinase deficiency is the retic count is very high in these children. It is around 20%, 30%. So whenever you get there is no other disease in which the retic count is so high. So you have to give even whenever you have such things, when the retic count is very high, you know the diagnosis is very clear. Okay, and the treatment is mainly frequent blood transfusions, and if excessive iron load is suspected, then we need to give chelation therapy. Then coming to the autoimmune hemolytic anemia, antibodies leads to premature destruction of RBCs. Okay, they can be acute type or a prolonged chronic course. In acute type, it is around 3 to 6 months in which a children they have a precipitation by an infection, mainly the respiratory viruses, which can lead to acute hemolytic anemia. While a prolonged course are more frequent in older children more than 12 years of age, and the hemolysis can continue for years. So hemolytic anemia is divided into three types: warm antibodies, cold antibodies, or drug induced. The warm antibodies are mainly IgG type, it can be idiopathic or it can be secondary to causes like lymphoproliferative disorders, connective tissue disorders, ovarian tumors, chronic inflammatory diseases, or immunodeficiency disorders. While cold reactive autoantibodies are mainly IgM type, which can be secondary to infections like mycoplasma, Epstein-Barr virus, viral syndromes, congenital tertiary syphilis. Then there are drug-induced type. Drug-induced have different methods by which they can lead to an hemolysis. That is, they can have a drug absorption on the surface and they can be presented and can lead to hemolysis. Then there can be immune complex formation, or there can be true autoantibodies formation against the drug. So all these causes, can lead to autoimmune hemolytic anemia, and mostly the congenital causes are less in hemolysis in autoimmune hemolytic anemia. Mostly acquired causes are much more common. The diagnosis is through the, we do a direct antiglobin test, we do antibodies which can be detected by indirect Coombs test, and we detect the warm antibodies, that is antibodies that are active at 35 to 40 degrees Celsius and they belong to IgG class. But cold antibodies, are active only at less than 37 degrees Celsius and they require a complement also for hemolysis. If the cold antibodies are present but there is no complement, then the hemolysis will not occur. Okay, so treatment of hemolytic anemia is through blood transfusions, and what we require in autoimmune, we require a immunomodulator, we require steroids. Okay, at the rate of 2 mg per kg per day. We can go up with higher doses also, and we give them around for 2 to 3 weeks and then slowly taper. But there are children who do not respond to steroids, and we might need to give them IVIG, we might need to give them plasmapheresis or rituximab. Okay. Then there is paroxysmal cold hemoglobinuria, which is, let's see, this is a cold hemoglobin. So you suspect it to be an IgM antibodies, but no. It is IgG type of antibodies, but they are active at lower temperature. That is, antibodies, they bind to the RBCs in cold, and the RBCs also require complement. Okay, but when the temperature is increased to 37 degrees Celsius. So they bind in a low temperature, but as soon as the temperature is 37 degrees Celsius, they lyse the RBCs. They don't lyse the RBCs when the temperature is less, they only bind to them. So that is an IgG cold reactive autoantibodies, and common causes are mainly congenital or acquired syphilis, okay, or non-specific viral infections. What the treatment is required is a blood transfusion, avoidance of cold temperatures, and you might require corticosteroids, splenectomy, and some patients may require rituximab. And if the underlying cause we know, we have to treat it properly. Now coming to the paroxysmal nocturnal hemoglobinuria, that is, if you remember, was an intracorpuscular cause, but it was an acquired cause. Usually intracorpuscular causes were hereditary, but this was an intracorpuscular cause, but that was acquired. What happens that because of the somatic mutations, these are not genetically inherited mutations, they are somatic mutations which leads to defect in the proteins of the RBCs, especially, there is defect in CD55, CD59, and C8 binding proteins. So mutations in the PIGA gene that involve in glucosyl phosphatidylate inositol anchor protein. So these leads to a abnormal shape of the RBCs and more hemolysis. Okay. So there is hemosideruria, there is haptoglobin and increased LDH, and flow cytometry is done to have a diagnostic test. Treatment of paroxysmal nocturnal hemoglobin is also steroids, and in rare cases they have tried monoclonal antibodies, that is eculizumab. This is the gist of how do we approach any child who presents to you with anemia and evidence of hemolysis in the form of reticulocytosis and in the form of indirect hyperbilirubinemia. Then we need to evaluate these children for hemolysis. And how are we going to evaluate these children for hemolysis? We need to get a good peripheral smear first of all, that will give us the evidence of what it can be. Just a minute. Yes. So it can give you evidence of what kind of cells you are seeing, whether you are able to see spherocytes, you are able to see sickle cells, you are seeing hinge bodies, bite cells, what all. And then you need to find out what kind of hemolysis is occurring. You have to find haptoglobin, hemoglobinuria is there, hemosideruria is there, indirect hyperbil is there, what kind of hemolysis is there. Then if you are sure, yes, there is a hemolysis, then we need to find the specific cause. So if we are finding more of spherocytes, okay, they're more of your antigen test is more positive, then we know it is an autoimmune kind of hemolysis. If your spherocytes are there, but your DCT, ICT are negative, and there is a family history also, then you have a hereditary spherocytosis. If they are schistocytes and there is a underlying cause like DIC is there, HUS is there, ECMO is there, or burns is there, then you are more sure that it can be a microangiopathic kind of hemolytic anemia. If there is hypochromic anemia, thalassemia has to be ruled out, sickle cells. Then if there is an exposure to some drugs and it's only an acute episode once, then you have to look for the underlying drugs which might have caused and precipitated J6PD deficiency. Then if there is fever, then you have to look for infections like malaria, bacterial cultures needs to be sent. So this is the in-end approach of the hemolytic anemia, which you need to remember. So just remember the investigations are similar in basically all. You just the diagnostic tests differ in all specific. If you are sure that I have reached a point when I am very sure that this is the test, then you go for the specific test. First, you have to confirm that yes, there is a hemolysis. And what kind of hemolysis am I looking into? Is it an acquired? Is it a genetic? It is an intracorpuscular. So, what kind of hemolysis is happening, which will help you in coming to a conclusion of the underlying cause, which is important. Okay, and then you have to follow some algorithms because symptoms are not different, treatment is per se not different. Just like we give steroids in your acquired causes, we need to do splenectomy in every child after 6 years of age. Okay, we need to give regular blood transfusions. So the per se your approach or treatment, your diagnostic features are not much different. What is mainly important is the the reaching the specific diagnosis, because genetic counseling depends on that, the particular treatment depends on that. Okay, whether it is a treatable cause like thalassemia, sickle cell anemia, if we don't get a stem cell transplantation, it is not a treatable cause. We need to tell the family the medications, the blood transfusion required is persist lifelong, and they might have a reduced lifespan. Okay. The key messages for today were: evaluate newborns which have high indirect hyperbilirubinemia, that is, they require exchange transfusion or phototherapy to look for the hereditary cause of hemolytic anemia. Look for atypical cause if the microcytic anemia is not improving with your iron supplementation. And peripheral smear is very informative along with their absolute retic count. Children with splenomegaly, anemia, gallstones or leg ulcers need to be evaluated. Chelation therapy is beneficial if frequent blood transfusions are required to prevent the complications of iron overload. And delay splenectomy, like till 6 years of age, vaccinate the children priorly, and post splenectomy give penicillin prophylaxis to them. So these are the key messages. And if there are any questions, I'll be happy to take them up. I know this is a really a vast topic. There are multiple things coming together in this, so I'll suggest you to go and read also one, so that if any doubt, you can always contact me back, or if any query is there, we can discuss it later also. But it's one of the important topics because anemia in children is very, very common. Splenomegaly, hepatomegaly, anemia, not responding to iron, it is not an uncommon feature. So you need to know that. Then it becomes whenever you are presenting a case in your final exams, a case of hepatosplenomegaly with might have anemia, then one of your hemolytic anemia might be a differential diagnosis. And also it is an important part of your theory exam also. I'll try to share my PPT and I'll let you know, guys. Okay, I think that's for today. Thank you so much.